30-year-old Thai male patient with no underlying disease. He's diagnosed with a recurrent anterior shoulder dislocation of the right shoulder. So the history is that he has a recurrent dislocation for 15 years. 15 years ago, when he was 15 years old, while he was playing the badminton, his right shoulder was dislocated and in the abduction and external rotation position.
Stop first. So 15 years ago, how old is he?
He is 30 years old right now.
Okay. อายุ15เหรอ
ครับประมาณครับ
15เนี่ยเล่าให้คุณหมอฟังนิดนึง
ตอนนั้น
เล่นแบด
เล่นแบบครับอยู่ใน
แล้ว
การเรียนแล้วก็เหมือนยกแขนตบตีอย่างเงี้ยแล้วมันน่าจะผิดท่าครับ
หนักไหมปวดหนักไหม
ผมหนักครับ
ตอนนั้นหนักใช่ไห
ค
ม
รับ
ปวดตุเมื่อกี้ท่าเหมือนไม่หนักเลย ท่าจริงๆคืออย่างนี้ใช่ไหม
ใช่ใช่ใช่ครับ
อ๋อไม่ใช่เคาะอย่างนี้นะ
ก็คือง้างสุดเลย
สุดๆเลย
ครับ
แล้วก็ไหล่มันหลุดตามออกมากับลูกแบบเลยใช่ไหม
อืม
รึด
ครับ
อย่างนี้เลยใช่ไหม
ใช่ครับ
เบี้ยวเลยใช่ไหมแขนร่วง
ครับคือตอนนั้นแบบปวดมากเลย แล้วก็
ขยับไม่ได้
ครับ
ไปห้องฉุกเฉินไหม
ไปครับ
ไปเลยใช่ไหม
ไปเลยครับ
Okay, that should be the dislocation because he cannot play. Need to go to emergency room for the reduction. ตอนอายุ15 นะครับ 15 ปีนะแล้วก็คุณหมอเขาดึงเข้าที่ให้ใช่ไหมครับ แล้วก็หลังจากนั้น
ประมาณน่าจะ2 ปีนะฮะ
2 ปีเล่นแบดอีก
ไม่ได้เล่นแบบนั่งเฉยๆแล้วเป็นจังหวะเหมือนเอื้อมมือไปข้างหน้าแล้วก็หลุด
So the history, the mechanism is not so severe because most the normal people they would have dislocation in this kind of activities, So if the patient have this history of dislocation, you should thinking about the patient that have multidirectional instability. The patient may have the congenital loosening of the joint, or they may have some connective tissue disease like, or they may have some connective tissue disease like, let's say like earlier than loss, Marfan syndrome. Those patients would have very lax, tissues because of the collagen, right? But some patients have like multidirectional laxity, and they can have the easily dislocation without any serious trauma. So I'm thinking about that because the mechanism is not too bad. But he said abduction examination, that's reasonable. But the second time dislocation, the mechanism is so simple. แล้วครั้งที่ 3 เป็นยังไงครับ
3 ก็
หลุดง่าย
หลุดง่ายๆเหมือนกันครับ
ๆไม่ได้เล่นกีฬาอะไร
ครั้งที่ 3ไม่ได้เล่นกีฬาเหมือนแค่เอื้อมมือไป
ครั้งที่
ครั้งที่ 4เล่นแบบ
4อ๋อยังจะเล่นแบดอีกเหรอ
คิดว่าคงไม่หลุดแล้วมันก็เลย
โอ้กี่ปีอะห่างกันครั้งที่ 4เนี่ย
ห่างจากครั้งที่ 3อีกสัก 2-3 ปีนะครับ
ก็คือหวดอย่างนี้เหมือนเดิม
ครับ แต่คิดว่าไม่ได้รุนแรงเท่าครั้งแรก
ไม่ได้หนักเนาะ
ครับ
ครั้งที่ 5คือเอามือเอื้อมข้างหลัง
ครับ
หยิบของหลังรถ
นั่งอยู่ที่บ้านแล้วเอื้อมไปข้างหลัง
ก็หลุด
ครับ
หลุดรอบหลังๆนี่เอาเข้าเองไหม
ไม่เคยเอาเข้าเอง
ไปฉุกเฉินหมดเลย
ไปในโรงพยาบาลทุกครั้ง
ที่ไหนส่วนใหญ่ไปที่ไหนปทุม
4 ครั้งแรกไปที่ลำปางครับสมัยก่อนอยู่ลำปางแล้วก็ตอนเรียนธรรมศาสตร์ก็มาเข้าธรรมศาสตร์รอบหนึ่งแล้วล่าสุดเข้าที่โรงพยาบาลตำรวจ
เปลี่ยนโรงพยาบาลไปเรื่อยๆ Okay so it has multiple dislocation that means has the history of the instability but first time of the dislocation when he was 15 any meaning any significant
If the dislocation occurred before the patient is around 20 years old, they are very prone to recurrent dislocation.
So you have higher chance of redislocation, right? More than 90%, right? So if the first time dislocation, the patient younger than 20, from the incidence, the patient may have dislocation again, 90%, 90 to 95%. So you can predict that this patient will have recurrent dislocation after that. And also the mechanism of injury, if that's not so serious, like a minor injury, that means the patient have the underlying disease or he prone to have redislocation again, right? So totally 5 times, so that is the candidate for surgery, right? Okay.
Doesn't have any.
Pipon, show me how to examine this patient. No. Okay.
Comparing whether there is a bony stepping of the bony, like swelling and inflammation, and I see no like inflammation and no like bony prominent, that is different. And after that, palpate the joint, the AC joint here.
That's colloquial process.
Here.
No, that's too
This
proximal. That is sternoclavicular, right? Yeah, sternoclavicular. It's like S shape, right? Clavicle. So AC joint is here. Yeah, you feel? Right?
Yeah.
That's his AC joint. Right? Okay,
The AC
normal?
joint is normal. And
Any atrophic change of the muscles? Deltoid?
deltoid, there is no like flattening of the deltoid. And other than that, we come to the motion. Ask the patient to actively
ยกแขนขึ้น
ยกแขน
ชิดหู
ยก
เล
แข
ย
นชิดหูทั้งสองข้างเลยค่ะ
ถ้ามันติดสาย
อันเป็นคนไข้ยกได้ดีค่ะแล้วก็ให้คนไข้อ้าแขน
Careful.
ลองเท
สบายเนาะ Abduction
ก็
Examination
เอาขาเขียนไปข้างหลังคนไข้ทำคนไข้ทำได้ดี
Good motions, okay?
Good motion ค่ะแล้วก็ก็เทสrotator cuff muscle
English version.
อะไรนะ
English version.
Oh, then.
Why you switch the language?
Okay, we come to the spatial test. We test the rotator cuff muscle. We come to the supraspinatus. Ask the patient to do the job test.
Yes.
Ask the patient to do like this.
Job test.
And then
Is that right?
ต้องเป็นแบบนี้
No. Okay. 30 degree. Okay. Parallel to the scapular plane, right? So this way. So rotator cuff.
ค่ะแล้วก็
Where's your hand?
Here.
No.
Here.
You stabilize the scapula. Okay. And release it. Yes, that's right. It's good.
ดีค่ะแล้วก็ทำดูinfraspinatus ค่ะให้คนไข้ทำ
English version.
Okay, so we do the infraspinatus test doing the Hawking. Kennedy stabilize this one and ask the patient to resist the
Hawking
force.
Kennedy. Are you sure? Infraspinatus test.
เป็น
External rotation.
External
doing
rotation.
like this and external rotation stress test.
Very good. This is external rotation stress test. Good or not?
Good.
Pretty good.
And
Next.
we come to teres minor.
Yes.
Ask the patient to external rotate.
Careful. This position. You tend to dislocate in this position.
Yeah. And ask the patient to resist the force.
Yeah, it's good. Yeah.
And then doing the belly stress test, press test.
Belly?
Testing belly press test.
Belly press.
Testing the subscapularis. And
Yes.
ask the patient to resist the force.
Yes.
It's
It's good.
good.
It's good. So other cup good.
Yeah.
Yeah. Next.
We
So dislocation in the young and in elderly is different, right? If the patient dislocation in the young, the pathology is mainly on the capsule or on the rotator cuff. Which one? In the young.
Capsule.
Capsules. Capsulolabal complex. We call capsulolabal complex. You know capsule is next to the cartilage. It's the capsule. It's the deepest part of the structures. And then cover the capsule again. This is rotator cuff. So in the young, you should focus on the capsulolabral problem, right? But in elderly, let's say the patient older than 40 years of age, so the patient may have torn rotator cuff also, because in elderly, the cuff is not elasticity of the cuff is not so good. And the pathologies in dislocation in elderly is mainly on the rotator cuff, especially the supraspinatus and the subscapularis. Okay. So this patient, the pathology is not on the cuff.
Yes.
Then you're looking for the pathology at the capsule, right? How to check that?
Maybe ask the patient to do like near test.
Okay. So you know how to reduce the shoulder, right? I already discussed with you last week. Okay, if the patient have dislocation, check the axillary nerve every time, musculocutaneous nerve, and then do the reduction. You can do anyway, like traction, counter traction, or modify traction, counter traction, or Mills position, Mill or Saha. Okay, reduce the shoulder joint. Okay. So after the reduction, now we need to check that the patient do have the residual laxities or not, or residual instability. So for the anterior instability, the test is that reproduce the pain again, because the position of dislocation is abduction, external rotation, right? Okay, same like we do patella, right? We push to the lateral side to reproduce the pain, or mimic the mechanism of injury. Okay, so the mechanism of injury is abduction, external rotation. We're starting from 45 degrees of an side first, right? This structure is the rotator interval, right? We're starting with 45. นี่เสียวหรือยังครับนะอันนี้เสียวเล็กน้อยเนาะที่90อันนี้จะเริ่มเสียวนะ so when you do this way you need to be very careful. You stabilize the scapula, okay, and drive. Then you do slightly abduction, external rotation. เสียวไหมครับเสียวนะเหมือนจะหลุดใช่ไหมครับนะ so very careful. If you do too aggressive, the dislocation will be in your hand, right, by yourself. Should not do that. Okay, abduction, external rotation. Then the patient feeling like it's going to pop out. You stop. Okay, and then we go higher, 120. Okay, so this position will be very easy to dislocate. So very careful. You stabilize the shoulder and then slowly rotate. Use your hand to slightly do external rotation. ท่านี้เสียวไหมเริ่มยังเริ่มแล้วนะเริ่มแล้วนะ so that means the patient have the problem of this the anterior instability problem, right? So that is the anterior apprehension test. So you do the posterior apprehension test by mimic the mechanism of posterior instability. You remember posterior instability? Adduction, internal rotations, and axial load, like dashboard. Like the hip injury, right? You do adduction, flexion, internal rotation, and that's axial loading. Same like the hip, right? We stabilize the scapula, so this like pelvis, okay? Okay, and then we do this way, okay? Push, okay? If the patient have posterior labral tear, okay, the patient would have pain, right? In this position. อันนี้ไม่เจ็บนะไม่เจ็บนะ The posture should be good. This patient, I think, has an anterior instability problem. Then I can check the posterior inferior. Okay, we push this down this way. Okay, to check the posterior inferior. This is posterior. This is posterior inferior. It's like a clock, you know. So you push to the opposite direction. If you want to test this, you go higher. You check the posterior inferior. Okay. ท่านี้เจ็บไหมครับท่านี้เจ็บไหมครับท่านี้เจ็บไหมไม่เจ็บนะโอเคนะฮะ Okay, now this is we call Kim's test because it's proposed by Dr. Kim from Korea. Okay. Okay, pretty good. And then we check the superior. Okay. Superior is the location of the biceps long head attachment. So this is the test for the superior we call O'Brien test. Adduction, internal rotations. เก่งไว้สุดหมอเก่งเจ็บไหมฮะไม่เจ็บนะ So this is the O'Brien test, and then you do supinations. เก่งสุดเจ็บนะเจ็บนะ So this is a test for the superior. Okay, so you check anterior by this position. This is posterior, and the superior you go this way. Okay, this is O'Brien test. So we now check all the labrum. We think that the problem is the labral or capsule labral problem in the front. Okay, good. So let's go to X-ray. So if the patient have the history of the dislocation, you should see the first film. มีฟิล์มตอนที่หลุดอยู่ที่นี่
ไม่มีครับ ตอน
เคยมาดึงที่นี่ไหม
อ๋อต้องธรรมศาสตร์
แต่ตอนนั้นน่าจะประวัติน่าจะหายเลย
ค่ะ
เกิน10 ปีอ่ะ
ประมาณ10 ปีนะคะครั้งที่ 4 กับครั้งที่ 5 หลุดห่างกันเกือบ10 ปีนะคะ
10 ปีเลยเนาะโอเค But from the history, he should have the history of dislocation. You see that what happened on the humeral head, okay? Okay. You can see that this is the lesion, right? This is the heel sac lesion. That means the patient had dislocation. Heel sac is because when the shoulder dislocate like this, okay? This is a crinoid. Okay. So when the shoulder dislocate, the head will be locked. Okay. Here. You know. On the glenoid or on the coracoid, it depends on the type, right? So when it's locked, so there will be like impression fractures, right, on the humeral head. So that's this the defect. We call this heel sac lesion. Heel sac. Okay, heel sac lesion. That means this is the clue that tell you this patient have the history of dislocation. Sometimes the heel sac small, sometimes big, right? If the heel sac very big, I have some patients that's so big like this, so big. In that situation, sometimes you need to transfer the bone graft from somewhere, from iliac crest or from cadavers to fill the defect. Okay. So, but this patient, I think the heel sac is pretty small, right? Should not the problem. Okay. Next. Yeah. Okay. So this is the view. Some patient may have this broken. See, this is a glenoid, right? Sometimes in multiple dislocation, this piece of bone broken. Okay. So that is a glenoid defect. We call that bony Bankart. Okay. Bony Bankart lesion, right? But if it's just the soft tissue, we call that soft tissue lesion, Bankart lesion. But if that soft tissue connecting with the bone or that bone broken with the soft tissue, we call that bony Bankart, right? Okay. Okay, this is striker notch view. There's some special view that you can see the pathology better. So this is the heel sac, right? So our plan today is to do the stabilizations. Okay, let's say this is the West Point view. So I think for him, the plan is to do this. Okay, this is the glenoid. That's the head, right? Okay, it's like ball on the tee golf. This is like tee of the golf, right? because the head is bigger than glenoid. His problem is that the labrum, this is a labral tissue that should attach to the bone like this. So this labrum makes the socket deeper. But his problem is that this tissue is torn, okay, with the capsule. This one is torn from the bone, like this. So our job is to reduce this back and fix it to the bone. So today we plan to put the we call suture anchor. It looks like screw, right? Put in the bone, and then we fix this back. Okay, fix this back to the bone. So finally, that will be like this. Okay, this will fix back to the bone, and the joint will be stable again. Like this. Okay, after the fixation. So this is like axial cut view. Okay, so we do this about 3-4 anchors, depends on the pathology. อันนี้คุณหมอจะไปส่องกล้องนะแล้วก็จะเย็บตัวที่ฉีกครับกับที่กระดูกนะครับแต่หมอคิดว่าข้อต่อคุณน่าจะหลวมตั้งแต่แรกๆด้วยนะครับเพราะว่าเท่าที่ตรวจดูเนี่ยมันค่อนข้างจะหลุดง่ายมากนะ And don't forget to check the patients that he have any laxities. We call biter score, right? Okay, อันนี้ไม่ถึงเนาะไม่ถึงนะ So we have 9 points of biter score. You know biter score? Yes, right? This first score. If you have both sides, have 2 points. Okay? ไม่ถึงเนาะไม่ถึงนะแต่ก็ค่อนข้างหลวมนะ Okay? That is the thumb to forearm, and the second one is the finger is parallel to the forearm, right? There's 2 points, both sides. Then the elbow hyperextensions, okay? But he's less than 4. Then knee hyperextension, and the last point is the hand to floor, okay? But from the score, he's not that bad, right? But anyway, some patients have the good score, but they have laxity of the joint, right? โอเคครับเดี๋ยววันนี้คุณหมอเข้าไปเช็คแล้วก็จะเย็บให้แน่นนะเรียบร้อยนะครับหมุดที่ใส่เป็นหมุดละลายนะไม่ใช่เหล็กนะครับมองไม่เห็นไปเลยครับ